Welcome to SEVA VentRounds. I'm Eduardo Mireles, and today's May 4th, 2021. And today we're going to present a series of cases that I call them the ultimate cases of trigger A desynchrony. And I think these will come to terms in a couple of seconds as we go through them. Some disclosures. We will discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. I'm Eduardo Mireles. There's my conflicts of interest. And Rob Chatburn also has this conflicts of interest today. Rob will not join us. The ground rules, these are recorded sessions, so keep your microphone muted, please. The moderator may call upon members of the audience to comment. You can do so by either the chat or when we ask for comment, just unmute your microphone and go at it. If you want to comment, again, use the chat function. We use a web poll to elicit audience interactions. As you know, for those of you that have done the SEVA VentRounds before, we have a pretty standardized way of going through the waveforms that helps us understand what's going on with these waveforms. And so I will say that at the end, there's going to be a QR code. One of them is for the CME. If you're a Cleveland Clinic employee, you can get continuous medical education points doing this. And there's going to be another QR code, which actually takes you to the web page where the link for this WebEx poll, and so you can distribute it to your friends or team members. Remember, this is free, and we enjoy the visit from anybody that wants to be in these ventilator discussions. I like always to ask or start by polling the audience and just type in the chat where you're joining us from. We've had people join us all the way from Hong Kong, a lot from the US, Europe, Mexico. Hara, who's one of our regular visitors, visitor from Lebanon. Marco from St. John, and Scotland, Canada, Pakistan. I mean, so this is wonderful. This is how we all learn together. So welcome all over. And if you want to continue putting, that's great. That's also a good way to learn how to use the WebEx features as they're present. All righty. So this is the first waveform that we're gonna start with, and I'm gonna put the poll for all of you to start putting your input. And so have no fear, start filling this out, and I'll ask any of my fellows if anybody wants to take a trial with this waveform, one of the ultimate cases of a desynchrony, a trigger desynchrony. So any of the fellows interested in taking a look at it? Either send me a message or unmute yourself and say, Eduardo, I'm ready to do this one. Have no fear. This is a safe space. So all of us are learning, and I will tell you more about the story of this waveform after we interpret it. See, people are answering. We have. So go ahead. I'll give you. There's still time. One more minute. Alrighty, I'm gonna close the poll. So keep putting, you have 20 seconds left. Alrighty. So any of the fellows jumped in that wants to take a stab at this?
I can give it a roll.
All right, Chip, I'll take the pen, get ready for it, and we'll go over the polling results at the end.
Right.
Okay.
Alrighty. So the tag is PCCMVS.
Okay.
And then the load, I'm going to say, is PMOS.
Okay. During inspiration and expiration too?
During expiration, I don't think there's a lot of PMOS, but there is artifact that makes it kind of hard to appreciate. But I think looking at the second to last breath there, you can kind of see it going out a little bit. So maybe, if anything, a little bit of resistance.
Okay. Very good.
And then for trigger, there's some problems here. Let me see. So this second one, the second breath, that is a double trigger. It's a patient and then a patient trigger again. So I think that's going to be a cycle issue, actually. So I think the trigger is going to be, oh, it looks like maybe there's a missed trigger, which I guess we'd say failed.
Sorry.
Oops. Yeah. So let's say a failed trigger after the third breath there. One more, right? Yeah, right there. Looks like a failed trigger to me. And then inspiration, I think there is some like mild, moderate work shifting. You can appreciate that in the second and fourth breath. Maybe the last breath as well was partly cut off.
Okay.
Yeah. And then, so cycle, I'm going to say that this is early cycle. I think we could make an argument that it's another false trigger, but I'm going to go with early cycle for this one. That's the third breath there, which I think because it's patient trigger followed by patient trigger, it's probably it cycled too soon and triggered another breath there.
So this one over here, early cycle.
Correct. Yeah.
From right there.
Right.
Okay. Okay.
And then expiration, we've got this kind of oscillation going on, which I don't know exactly what it is, but I would hypothesize either there is some like some water in the ventilator tubing, or you're picking up the patient's heart rate, but it seems pretty quick for heart rate. So I'm going to go with fluid in the ventilator tubing. But otherwise, I don't see a lot of expiratory work.
Thank you, Chip. You jumped into this one is a big bull in a bullfight. So you jump to a big bull without a doubt. Thank you for doing so. I'm gonna share the responses. Can you see the responses already for the poll?
No, I don't see the responses.
So what?
Yeah, I do. I'm sorry, I see them.
All right. So majority of people agreed with you on terms of the tag. They thought that this was PCCMVS. A minority of them thought that this was servo or IMB. There was one person that thought that there was a resistive load, and the majority of them thought that there was PMOS as the driving load. In terms of the cycle, there's three answers that appear. There's early trigger, there's false trigger, and there's failed trigger here. Majority of people agreed with you in terms of the work shifting being mild. The cycle, some people recognize this as an early cycle. And in terms of expiration, majority of people thought that this was expiratory work. So I will pause for a second and ask for comments from the audience. Anything different that you felt while looking at this waveform? And have no fear. This is a tricky one. You can write it on the chat or comment. All good. All right. So let's dissect this one together. Yeah. So Mohammed Megri said false trigger due to recoil artifact. All right. So this one has everything that you ever wanted to see. Almost everything. It's one of those that it's hard ever to capture something with so much data. So the first one is what is the tag? I think that in general, I agree completely with you. This is pressure control. So you can see how well controlled is the pressure. It's essentially a square waveform. All of them are controlled, and we know that because even though they're patient triggered, or the ventilator thinks that they're patient triggered, they end at an inspiratory time, and you can see that clearly on this second or third breath when there's no flow, and the ventilator is just maintaining the pressure because you set an I time on this patient. So definitely this is pressure control, CMBS, and the classic manifest or name on this ventilator is pressure control. So I'm going to touch on those points from Aman and Hara. So what is the load? And I think that the first one during inspiration, you recognized appropriately that there was effort from the patient. So actually you can see how the pressure drops below baseline and then eventually triggers the breath, and the breath pressurizes. This, instead of going down in a nice, beautiful exponential decay, it actually kind of looks pretty straight. It's not much evidence of effort. Perhaps here looks a little bit more passive than anything with the decay. And if anything, this one would probably highlight that there could be an increased resistive component. But PMOS, I would say it's my first drive. Then comes the expiration, and I applaud your attempt. You have two things that are key here. The first one is you recognized appropriately this event over here, which is a failed trigger, also known in the literature as a missed trigger. And that usually means that there's an issue. It could be, there's many etiologies, but one of them, and the most serious one, I would say, is the presence of auto-peep. And you can potentially see two features that tell you that there's auto-peep, one being this one that I highlighted here in the first blue arrow or over here. The second one is this one over here. You see how the flow is not returning to zero over a period of time. And although this could be effort, the patient doing effort to exhale, it also may highlight that there is a resistive. And the third one, which is a little bit more nuanced, is this recoil event that you see here. And we're going to talk more about it. But essentially, this type of ventilator has a feature you cannot activate or deactivate, to my knowledge. It's just something that the engineers put there. That when there is an increased resistance, in order to keep the PEEP at the set level, the machine will, based on the calculated resistance and compliance, will drop the pressure to try to get you to that point instead of having a decay like this, so that the pressure will reach the set PEEP level as fast as it could. And that, in our experience, we have seen it when there is evidence of increased resistance in the airway. So just for you to keep that in mind. So I think that you read, Chip, of having an increased resistive load is outstanding. And I think many of the team caught that. Then comes the trigger. And so I will take you through this in order. Let's start with the first one, this one over here. Okay. So if you look at it, Chip, it's a pressure trigger. So you can see that somebody set the trigger to a pressure threshold. Instead of using a flow threshold, they decided to use a pressure. And you can see that this breath, there is a decay in the pressure below the baseline in this one, and in this one. Actually, if you realize the flow actually has crossed over the baseline, meaning that the patient is sucking in and saying, I need the breath, and eventually, ploop, the system pressurizes. And you could argue or actually think that the effort started here and it took all this time to pressurize. So the name of this is late trigger. So the patient is taking a longer period of time to trigger the breath, even though there's presence of effort. And in this case, it could be because they set the threshold for the pressure triggering too high. And it could be in response to actually what's happening down here that we'll see in a second. But this patient is having work to trigger, and we would call this one as a late trigger. So that's the first finding. And I will now use questions about that. Any disagreements from the team? All righty. The next breath, this one over here, you recognized that there was some PMOS, but it's not major PMOS, and the flow essentially reached zero by the end of the breath. Suddenly the patient exhales and the ventilator exhales, and rapidly it crosses and it triggers a new breath. And that new breath, essentially the patient gets zero flow during it. And actually you can see here that there's no volume. I mean, there was this little tiny amount of volume that the patient got. And so that makes me suspicious. The presence of zero flow at the end of the breath and no evidence of PMOS afterwards makes you think that something is going on. And what's going on is actually these reverberance that Mohammed was bringing up, and that I saw also a man talk about it. And this is this time controller that it's a feature that they put on the ventilator to try to keep the PEEP at level. And actually, if you average these oscillations, the PEEP was exactly where we set it. But it had to do these up and downs, and it's all driven by the ventilator in a patient that has high resistance and low compliance. And so it will do these oscillations. And you can see clearly here how it's crossing the baseline. And the same over here, it crossed the baseline and it crossed the baseline over here. And so that means that most likely the caregiver that was the RT that was doing the care for this patient said this patient is triggering, having double triggering, and they change him to, or her, to a pressure trigger. And so this is actually a false trigger. This one that you have over here, this is a classic case of false trigger due to a ventilator algorithm that is misreading the patient. And then the third one, the third issue in terms of triggering, and I'll put it in blue, is what you pointed out right here. And in this case, you can actually see how the flow is crossing again the baseline right here. And the pressure actually drops, but it doesn't drop below the threshold that had been set by the respiratory therapist or caregiver that set this ventilator. And because of that, the ventilator did not trigger. And this is a case of a failed, or also known in the literature as a missed trigger. So in this simple tracing, we have a case of late, a case of false, and a case of failed triggering, which I thought that was just fascinating to find in one single one. In terms of inspiration, the situation was, I agree completely with you, it's mild. If anything, there's a little bit of work during inspiration and obviously during trigger. So we, as caregivers, we should actually take care of this trigger issue because it's creating more work. In terms of cycle, I think that you could argue that there was early cycle here, but with these reverberations, I cannot see actually much PMOS happening there or here. So I would, with the exception of this one over here, which is a late cycle, because if you consider this PMOS, this would be a late cycle, but there's no activity. I don't think that there's any PMOS. So this will technically be a normal, if you remember that this is all in reference to the patient, if there was PMOS or not, and I don't think that there was PMOS there. And then finally, expiration. And in expiration, we don't see much the patient trying to exhale out. This could be expiratory work, this one over here, meaning the patient is exhaling against something that is impeding the flow. And you have these oscillations. They are actually, the first time I saw them, I thought of flutter. It looks like the patient has the flutter waves on this, and the patient, it didn't have anything to do with the rate of the patient, with the heart rate. There was no correlation. So actually, when we saw this, we also read this as there may be some fluid or secretions on the airway. The patient, but that was not the case, and we'll see the cause anywhere. So let me address these the questions that or comments that have come. False trigger due to recoil artifact. Absolutely right, Mohammed. That's what triggered the false trigger. Almost no PMOS before the double trigger. Exactly, Aman. That's why we think that this is a false trigger. The oscillations in the expiratory phase decrease in amplitude progressively, which is weird for fluid. And you're right, Hala, or Halal Hara. For these ones over here, there is no question in my mind that this is due to the algorithm on the ventilator. But these ones over here are different. These ones that are in the middle of the waveform are due to obstruction. And you'll see in a second what's happening is that the pressure inside the airway is higher and the air is escaping. And so it's doing something similar to, I don't know how to say it in words, so I'll do it with my mouth. It's doing something like this. And you'll see why in a second. It's pretty cool. No, it's not expiratory valve malfunction. It's doctor malfunction. And so, very good. I agree with Mohammed. So let me show you what happened. Any comments from anybody about this case? Have no fear. This is a friendly environment, challenging waveforms, but really cool. All right.
Hey, Dr. Morales, this is Russell here.
Hey, Russell, go ahead.
With all these trigger issues, how do we fix this problem?
Excellent. So the question here is, when you see something like this in which there's more, there's a lot of items here. I like to just let's rephrase and rethink about this. So you're on pressure control, and the patient, there's features that are telling you that there's increased resistance with increased work of breathing, with a failed trigger, and there's features of increased resistance. So what would that make you do in this patient is assess the resistive component. Why is this patient having so much resistance? And usually that's not, it could be an issue with the ventilator, the expiratory valve malfunction, obstruction of the ET tube and whatnot, or you're standing on the tube that, for the patient. What I'm going to show you, this case, so actually this was one of my patients, and what you will see, this is a fragment of the x-ray. This is the aorta, and you can see a little bit of the vertebral bodies and the ribs. And I did this yeah, that's her tracheostomy. So she has a tracheostomy in place. If I take it out, you probably can see it on off. And this is a patient that was failure to wean from mechanical ventilation, and she was sent rapidly to us because of issues with the ventilator. They could not ventilate her at times. So a bronchoscope went in, and this is what you see, the reinforced tubing, and it's against the posterior wall of the patient. So those oscillations that we were seeing, were when she was able to overcome the pressure enough to get air to escape from it. So the bronch was replaced, and the trach was replaced. And I put here a negative of the now in the middle of the airway, and you can see the reinforced. So it was hitting the posterior wall. And the reason why it was hitting the posterior wall, this is a sagittal cut of the patient, and you can see that she was kyphotic. And when the trach went in, it was hitting the posterior wall because it could not do the curve completely because of the soft tissue. So she had to get an extended length tracheostomy to deal with it. So the overall message is, as you look at this waveform over here, in retrospect, this is a case in which the patient was failing to trigger. She was doing a lot of effort to trigger because it had to overcome the setting that we had to put because she had very high resistance because we were backwalling. And this is one of the features that you may observe when there is that backwalling on this patient. Actually, interestingly enough, is that the patient's tidal volumes would become lower whenever you went down on the PEEP. And so we went up on the PEEP. At that time, we had not thought that this was a backwalling episode of this patient. You went up on the PEEP and the tidal volumes would go up, which I guess that we were stenting the posterior wall against the mouth opening of the trach. So pretty cool. Comments? Yes. So here, this is a teaching case, I think. So the next case was actually a donation from this is from Chip Welte, so he cannot read it, but I can ask I'm gonna put I'm gonna put another poll for all of you. Please start answering, and I will ask any of my fellows to jump in. So here the poll is open. Start answering as you see this waveform go in order. And if any of the fellows wants to either text me or just unmute yourself and say, Eduardo, I'm up for it. Again, these are not simple cases, so have no fear. The goal is that we all together read through it and try to get to a nice statement of it. We have 2 more minutes. No, 1 minute and a half. Then I'll close the poll and we'll get to read it. And while we're waiting and people are answering, I would just say, do send me your waveforms. This is very useful because actually we put them in, and I'll answer as I can. Actually, I just recall that I have not answered to Richard Bolt. I will not forget you, Rich. And actually I wanted to incorporate it to this one, but I saw this case and I thought that we should focus on triggering. All righty, we have 20 seconds left. All righty, the polling has ended. Anybody wants to jump in and read this one?
Can you hear me, Dr. Morales?
Absolutely.
All right, I can give it a shot.
Thank you very much.
So the tag I'd say is BCCMVS.
Okay.
In terms of the load, so it depends on like which breaths, because there's some active, some passive. There's a lot of PMOS in the first few breaths, but there's a completely passive breath in the end. So I'll use that to kind of determine my mechanics. So in that breath, at least, it looks like there's resistive load based on the flow profile. PV discordance. So it's a pressure trigger. I can see there's a lot of dip in pressure before the breath is triggered, and maybe a little bit delayed too. So possibly some delayed trigger. And there's vigorous patient effort because it's a big dip in the pressure before the breath is triggered. And then inspiration wise, there's this PMOS in the first few breaths. So there's some work shifting in the first few breaths. Not much in the cycle wise. So okay, so this is a bit tricky here. So I think the first breath, what's happening here is the patient triggers the breath and then relaxes, and then there's this PMOS again. So there's initial PMOS, then patient relaxes, and there's PMOS again because the I time's so fast. So I don't know what you would call that. I'm gonna say delayed, like late cycle. There's no real work during expiration.
Thank you, Aman. This is a great read, really good. Let's see how the team did, and then I want to ask you some questions.
Sure.
Great job. So I think the majority of the team read this as PCCMBS, which is the right tag. We'll talk about that in a second. Some of the team read it as resistive and some as PMOS. The majority as PMOS. In terms of the trigger, there was a normal, some early triggering. That's very interesting, and actually, by definition, we can talk about it. And some false triggering. Inspiration, the majority recognized this as work shifting severe. In terms of cycle, early cycle for many, and some thought that this could be late, and then there was a half and half people saying normal and expiratory work. So let's talk about this waveform. So in terms of the mode and the tag, I think that you're absolutely right. This PCCMBS, not only do we have the high quality sign here on top saying that this is pressure control, but you have here the pressure, how it's controlled through the breath, and these deflections are a manifestation of PMOS, as you will recognize, and then you have this very nice breath, and all of them about the same level, so pressure control makes sense. And it's continuous mandatory ventilation because there's an I time, and you recognize that as every single breath is the same size, and even though there's patient activity, the I time remains. So these are all mandatory breaths. In terms of the load, you recognized, and whenever you're looking at the load and trying to figure this out, where I look at if I'm controlling the pressure, I look at the flow. And instead of having the nice decay that you should be having, actually like this one that you have here, or this one over here, or this one over here, this one is very nice, right? It decays exponentially, the third one. Yep. You have these bumps in between, and those bumps in between are because they're moving away from the baseline. That means that the patient is doing inspiratory effort. And so there's air going in. So I think that you cut this very well. There is PMOS that lasts, and I'm gonna put it in a different color so that we can see it better. So if I think about PMOS, there is PMOS during this period of time, then there's PMOS during this, so meaning inspiratory effort during this period of time, this period of time, sorry, this period of time, and then again this period of time, and perhaps here. So that's there's a lot of PMOS, and actually you can now look upstairs into the pressure waveform, and you see how it's deflecting the pressure during the inspiratory phase during the pressure, and that's the PMOS. The P vent can only go down if there's PMOS in there. And so you read that very well. This is all PMOS, and then after that, and actually there was still PMOS over here. You can see this is a early cycle, so somebody read that one appropriately. And then the next one is a passive breath, beautiful passive breath. And whenever you have a passive breath, as Steen said, that's when you look at the physiology. So the PMOS always hides the physiology. Passive humans, passive breaths show the physiology, and without that, you're not reaching zero here. You can see the time that it's taking for this breath to reach baseline, and at least that's a second and a half, and the same on this one. You can see how long it's taking for him to return. So that makes me suspicious, as it did you, that this is a case of increased resistive load on this patient plus PMOS. So there's no doubt that there's PMOS. Now, sometimes, and this is important to know, is some patients may take so much air in and they have not exhaled as much that it may take you longer to get back to baseline from a massive inspiratory effort. So that's you have to keep that in mind. But this one actually makes it another case that you were right. In terms of trigger, without a doubt, this is a pressure trigger. I mean, today we're seeing a lot of pressure triggers, and with this pressure trigger, it's actually dropping a fair amount. So the PP is set at 8, which would be around this level, and you can see how much it has to drop. So probably it's at -3 or -4 to trigger the breath for this patient. And I presume that what they're trying to abort or avoid are these multiple events that are happening here, these multiple efforts. So you could consider that each one of these are late in nature just because you set a very low threshold for it. So I would tend to agree with what you put right here. I don't think this is early for those that put early, because this is a patient trigger breath, and the next effort that exists is also a patient breath. And I think that based on the curve and how this looks, and actually what I'm going to show you later, this definitely is individual efforts that are occurring on top of the I time. And so if you think about this, it would be similar to what would you do in APRV, in which the patient is breathing on top with efforts on top of a mandatory breath. I do think that there's work shifting. The mere definition of this is you're dropping the pressure below what you are delivering to this patient, which is telling you that some of the work is being done by the patient. It's not severe because you don't drop below, although there's work of triggering. And then you recognize some late cycle by definition here, because there was still effort. For example, this is a late cycle. But this one over here, because there's movement up towards the baseline, this is an early cycle. So early cycle, late cycle on this one. So I would say both of them. And then in expiration, I don't see any work, though, meaning the patient bearing down. So normal would make sense. So the $1 million question here, well, not 1 million, I'm not going to give anybody money, but why is what's happening here? And so I would ask the audience, could we do to try to ascertain what's happening here? Any suggestions from the audience to try to figure it out? And I can tell you, well, yeah, go for it. Any maneuvers can you think of to try to figure out what's the PMOS on this patient?
Do expiratory occlusion.
Yeah. So essentially, yeah, that's right, Marco. And expiratory occlusion will help you to assess patients' breath of length and rate. So I'm going to show you. So this patient had too many things, but I'm just showing you one of them. So we did a end expiratory pause on this patient, and he went out of the scale, and we could not figure out how to move the scale so that it would be in the middle of the waveform, acknowledging that this is a relatively older ventilator. Maybe, hopefully, the new engineers can do that, but this is an end expiratory pause. You see there's nothing. There's probably these little deflections here that are cardiac oscillations for this patient, these little suckers here. And then suddenly there's the effort. You can see actually the changing color, that this is a patient, that the patient is starting that breath, and you can see the oscillations of this patient had in the airway, i.e. he was having this kind of hiccup tonic movements of the diaphragm at the same time, and then it would go out, no activity, we would trigger another breath, which was passive, as you saw on the other ones. So I've never seen anything like this before, but I think that the cause of this is very interesting. So Chip, you want to talk about what was the cause of for these tonic contractions of the diaphragm or respiratory muscles?
Yeah, this was a post-arrest patient with severe hypoxic encephalopathy, and these were like myoclonic jerks, kind of motions that was triggering the ventilator.
And so there was, we tried several settings changes on this patient to try to make him comfortable. The challenge that we found is that this was not the only desynchrony that he had. There were this evidently had affected severe hypoxia to also the brainstem, and so he would go into periods of hypoxia, of apnea, followed by episodes of BTOT ventilation. So a really challenging situation in which you have to maintain the minute ventilation for the patient in a patient that has a really dysregulated respiratory center. So kudos to Chip for recognizing this case. Very good. All righty. We have a little bit of time to do. Also, I wanted just to show this one, which is the time constant valve controller that I was talking about, and this is the feature on that servo ventilator in which they reduce the resistance in the beginning of expiration via this controlling algorithm in an attempt to maintain the resistance as low as possible and maintaining the set PEEP. So that's the thing that was sabotaging us on the first case, one of the several things that was sabotaging us in that first case. So this is another one. This is let's do this one in fast pace and see. Let me send a new poll. Yes, and say that no, and then open. And here goes the poll. And please read up on it. And if anybody wants to jump on this one, let me know. And yes, Aman, you mentioned a good thing. So if we can move the cursor, actually it's a touch screen, and you can do it with the hand or with the knob, and measure how low the pressure dips are during that expiratory occlusion test, or expiratory pause. It's really an expiratory pause. So absolutely, that's one of the ways to do that. All right. Yeah, and all these cases were in 1 week. It's pretty remarkable how triggering issues abound in our ICUs. Okay, I'm gonna give you 1 more minute. Remember, these polls are anonymous. I cannot see, nor I have interest in seeing who's answering what, so have no fear. Doing and 20 more seconds. And let's see, is there any of our fellows or respiratory therapists that want to give it a stab?
Dr. Morales, this is Samir here. I can take it.
All right, Samir.
So the tag would be VCCMVS. The load, depending on which breath you're looking at, I think.
So wait, your tag was PCCMBS?
VCCMVS. V
Okay.
as in violin.
See, yeah.
Looking at the load, I think there's definitely a lot of resistive load in the expiration. Looking at the time constant. In inspiration, I would say there's definitely PMUS in the second breath or the first breath, depending on how you look at it. The second breath, I would say, it's pretty passive. In terms of discordance, I think this is a early it's like a reverse trigger, like an early trigger, then followed by like a mandatory breath by the patient. That trigger sort of resulted in a lot of inspiratory work shifting, and I think I also see like a miss trigger in the expiration phase, like a failed trigger. Maybe there's some effort, but that didn't trigger a breath. And I think there's also some expiratory work shifting going on based on the negative pressure. I think that's because the patient is trying to take a breath and the machine is unable to deliver so. In terms of cycling, I think always the question in my mind is it early cycle versus reverse trigger, and I think in this case it's the cycling is normal. It's the trigger abnormality that's causing this abnormality. So I would say normal cycle, and then there's expiratory work shifting because of the failed trigger.
All right, let's talk a little bit in the last minutes. Thank you very much, Samir, for jumping on this one. Let's see what the poll read. So the majority of the group read this as PCCMBA. That means that this is an adaptive targeting. Some of them was the load was read as a combination. Actually, there's a good amount of PMOS and resistive load. The trigger, many recognize the early trigger, just a couple, the false trigger, or sorry, the failed trigger. In terms of inspiration, most thought that this was normal. In terms of cycle, majority read this as normal or early cycle, and in expiration, some expiratory work. So, all right, let's read this one together. So the key here, I'm going to switch color to yellow. The key here Samir, is remember when I look at the trying to decide what's the control variable, I look at the flow. And if the flow has a geometric shape, a square or a descending ramp, then and they are all the same, then that's usually volume control or flow control. And so in this case, we are actually, it's PRVC, in which we are actually targeting the tidal volume. So the target is PC, and it's adaptive, meaning that the ventilator is going to try to target a tidal volume by changing the inspiratory pressure. In terms of the load, I think that you're completely right. This one over here, instead of decaying nicely like it should, all of this is inspiratory effort from the patient. And actually, the breath ended, and there was still inspiratory effort. And you can see this is all evidence of inspiratory pressure effort from the patient. So yeah, there's PMOS. And you also read appropriately that there were features that tell us that there's an increased resistance, such as the slope is taking forever to get down to zero, actually never reaches zero. And it could be because either the patient is taking massive tidal volumes. You can see the tidal volumes were very large here, double trigger, but it got 650 on top of this one, which is around 850. And so this could be absolutely resistance on very large tidal volumes. The next one is the trigger. I think this one is well read. This is a mandatory breath. It starts with a mandatory breath. There's no trigger here from the patient. And it's followed by a patient activity. Early on, no doubt, but patient activity, all of this is patient activity. And thus all this is consistent. A mandatory breath that it's followed by a patient breath is an early trigger. And we use the term early trigger instead of reverse trigger to not confuse, because we don't know exactly what the physiopathology is here. We're just describing the timing of events. The cause may be varied, but in this case, it's an early trigger. And then you recognize very well, Samir, failed trigger here, which is a manifestation of usually auto PEEP, or that's one of the causes. It could also be over assistance from after having a very large breath, or issues with the trigger, which are not the case. Usually when it's an issue with the trigger, like in the first case, it will cross the baseline if you set it too wrong. So there's this failed trigger you read. This one has definitely work shifting, and this one also has work shifting. This one seems more passive, and it looks probably consistent with your resistive load, as you had said. So I think the work shifting exists there. The cycle, you're right. So whenever there is there's early cycle, it's very common to see, early trigger. It's very common to see also early cycle, which is what you see precisely right here. The patient ended and the ventilator continues. So actually this is a late cycle, late cycle. In this one, in this breath, this is a late cycle. And on this one, it's an early cycle, if you want to do that. So the key here is that that's why it can get very confusing, because then you're grading this one and that one. Is what caused all of this? It was an early trigger. And so I think that I agree with you with your normal cycle. And finally, expiratory work. I don't see clearly any expiratory work. Maybe some work here. I'm not entirely clear. This is it's following the exponential decay very nicely. So it decreases my challenge. Yes, thank you, Michael Fisher comments that trigger sensitivity is one of the most important settings one can manage on the vent, and I believe that if pressure trigger is often erroneously used to mask discordance, and evaluation is key. That's correct. This is usually an easy way to try to correct little desynchronies that you're seeing and say, okay, let's do this modification. And what you end up is with now another issue on top of that, which is a late trigger. I'm going to stop there. I don't know if there's any other comments or questions from the audience. Yes, Amanda, they were able to pass a suction catheter in the first case, but the reason why they sent the patient here was because the suction catheter, there was a moment in which they could not pass it. So they were able to pass it. I guess that in the travel, the trach got opened up again. So when the patient got to us, she looked very comfortable. And soon thereafter, she had another one of these episodes of I cannot ventilate the patient. And that led to the emergent trach revision and replacement. Here I have for you, as you know, send us your waveforms. I do keep them and I will show them out on these cases, and I may invite you to read on them. But we are learning so much from this data. There's the Twitter account, my email, and then the CME for CCF caregivers. Just scan this one on your right, on your left, and then the right one is for you to save that website. It's the web page. We had some trouble downloading to YouTube. It's not under my hands, but it will be. And so there's 3 videos, including this one, that should be downloaded in the next days. So with that, I want to thank you for your attention and time. I think that these were great cases and keep them coming. And if you have any questions, go ahead.